minutes before we get started. So we're going to be talking today about how to price your services in the world of early adopters. This is webinar number 3 of our latest provider readiness webinars. I'm going to describe, provide some overview information and then jump in. In terms of specific instructions, we're going to be stopping a few times during the webinar to collect information and feedback from everyone. Everyone's in listen-only mode to prevent background noise. There's 3 ways you can ask questions or jump in with comments. One is to use the chat. Type something into the chat box, which is in your display panel on the right side of your screen. Another is to tap a question into the question box, which is also on the display panel. And if you want to ask a question verbally, raise your hand by clicking in the column next to your name, in the hand column next to your name, and that will raise your hand. I'll be able to see that your hand is raised, and I'll unmute you. So those are the 3 methods that we're going to be using. For those of you that attended Adam's training last week on managed care contracting, I wanted to start with restating the contracting strategy that he talked about: prepare, evaluate, and negotiate. And this is part of that preparation work, as well as the evaluation piece. In his training, he talked about 3 areas of strengths that it's important to identify: assessing your leverage, increasing leverage or value, and competing based on value. Today we're going to be drilling into the value portion, specifically related to pricing. Now, in the first webinar that I did last week, we talked about the definition of value, and I listed it as there are 3 components of value that are unfolding in healthcare reform. Providing high consumer value, and consumers have said that they're looking for accessible care provided by staff that are knowledgeable about the service they're providing and also do a great job communicating. So that's a really critical piece of the puzzle. Also, being clinically effective, achieving individual and system-wide outcomes. And the third piece is being cost-effective, which we defined as the services you provide cost less than alternatives that achieve comparable outcomes. There's one more part I want to add to the cost-effective piece, which is part of that value equation involves knowing the costs of your services, then working on internal efficiencies to improve those costs and price them to reflect your future costs that are based on the improvements. So it's really important to not assume that if you have high costs, unit costs, or high cost per episode, that necessarily means that you provide great service, or it necessarily means that you're going to be competitive in a future environment. And so again, it's that cost piece that we're going to be drilling down into today. So let's talk pricing, which is very much related to cost. I'm wondering how many of you participated in the 2013 Southwest Behavioral Health Rate Setting Project? And for those of you that did, you may remember that we did this cost and rate study, and we came up with 5 recommendations around guiding principles, closing this client service gap, closing the rate gap, creating a different model for Skamania, and having a 3-year plan to leave fee-for-service, where we recommended that fee-for-service is an old payment model that is important to be thinking about paying, moving towards accountable payment models. We talked about those a lot a week ago, and what we're really looking at today is how to price services in an accountable payment model environment. And again, if you have any questions at any point along the line, including when we're going to take a station break, a couple of station breaks, please feel free to type in a question, type in a chat, or raise your hand. So for those of you that worked on the 2013 cost study, you may remember the cost study template. Since then, we've updated it. We actually have an outpatient behavioral health unit cost template, and we have a residential/per diem unit cost template. And I want to spend a little bit of time for those of you that didn't participate in looking at this template. I'm not going to go into painful detail, and for those of you that did work on it, to do a little refresher. But before I go there, let me say that there is a short answer to how to price your services, and it's really a 6-step answer. What we're recommending, it's very straightforward. Do a new cost study for your services if you haven't done one recently, and that includes all of your services. And you'll probably need to use a different template or create a different version for outpatient services, residential services, crisis services, and other service areas. Then you should consider tweaking the cost study to reflect any staffing changes you're going to make over the next couple of years, any efficiency changes you're going to make over the next couple of years, including improved costs, improved productivity, any streamlining that you're doing, and any other cost changes you will make over the next 1 to 2 years, including whether there's a need to beef up the services that, or the infrastructure support that you need to support the services that you're providing. And then to develop utilization management guidelines for each service you wish to price. And I don't know how much folks in the region have worked on internal utilization management guidelines. We're going to come back and talk about how critical this is. Determine which payment models you want to contract for. We talked about 4 payment models last week. I'm going to do a real quick run-through of those 4 payment models. And then convert the results of your cost study and utilization management guidelines into the relevant payment models. And finally, to package your results into a summary document you're willing to share with the health plans. Don't be afraid of being transparent as long as you're willing to walk away if a health plan's final offer will break your bank. And so there's different strategies around pricing, what to do once you price your services. What I think is important is to seriously consider putting the results of your work together and laying it out to the health plan, saying, we do great work, this is what we can tell you about why we do great work, and this is what it costs to run our services and to provide those services, and here it is in black and white. And that's a different strategy than others use to where they hold their internal costs close to the vest, but I would suggest that you consider this step 6. So really, it's 6 steps. So what we're going to be doing this morning is basically a technical webinar as opposed to a philosophical or policy-oriented webinar on how to go about tackling these 6 steps. So let's dig into the cost study. This is sort of the new and improved version. It's a little different than the one that those of you worked on in 2013. So in the Excel workbook, we'll be sending out copies of the new and improved cost templates. There's a help section so up at the top of the screen here where it says getting started, print this manual, go to the sample template and walk through the steps below, and then complete the input template. You'll see that there's a section 1, direct service provider, FTEs and salaries. There's 8 sections to the cost template. And so this is like really very straightforward, where you put in the direct service provider salaries and FTEs by clinician type for the employee types that you have. And you'll notice that there's rows that have the clinician types, and those get transferred over to columns for clinician types. When you put in your 0.3 psychiatrist, these are all data, so don't take these numbers to the bank, but when you put in how much you pay for psychiatrists in total and how many FTEs that you have, it basically pulls it over into the right column. So on the direct service provider salaries and FTEs, there's a little, I showed another version with the instructions from the help manual. I showed that there's additional rows for all the different kinds of clinician types, and those will reflect in the columns like we saw in the last slides. So for preparing the cost study, you basically need to study the template, go into your general ledger, your payroll system, your budget, determine where to get the numbers for each of these sections, and then to begin to fill it out. Now, there's a little bit of a difference between the costs for employees and for provider contractors in the way the benefits compute in the model. So we want you to do the same thing for the contractors, this is section 2. You drop the numbers in. You can see that I've gone through 2 of the 8 sections. I'm not going into detail about it. I'm going to stop in about 5 minutes and see what kind of questions that you have, if any. But it's really just to give you a flavor of how to fill this puppy out. And then in section 3, we've separated service providers from other staff, management staff, support staff, administrative and overhead staff. What some people have done is some people use these 3 categories. Wherever there's a yellow shaded cell, that means that you can delete it. You can type over it. Some people have said, oh, I just have 1 category of other staff that I want to use, or I just have 2 categories. That's fine, because they're yellow shaded cells. And in this case, I have 6.5 other staff that do those 3 things, and I entered in, again, the annual costs for the salaries and the FTE amounts. The allocation method I'm going to come to in just a couple minutes, but that's something that's important, and we'll be discussing that when we get to that slide. In section 4, payroll taxes and benefits, we're asking you to enter this in for everybody who works there, the others, in sections 1, 2, and 3. And again, you can put in whatever rows that you want. Now, where we're heading with this cost study is we're heading towards cost per hour for individual services, the cost per hour for group, and the cost per group for group services by each clinician type. And I'm going to show you what we're going to do with that when we get to chapter 3. But this is core stuff. If you need to know your costs by clinician type, per hour, and per group. In section 4, you enter in everything, all the non-compensation costs. and I'm sorry, section 5. And I want to just hum a few bars about the allocation method. So this is a little cost allocation tool, and what it does is it basically takes everything in sections 3, 4, and 5, 3, other staff salaries, 4, payroll taxes and benefits, and 5, other expenses, and it gives you a chance to allocate each of those expenses across the different clinician types. So for example, I have $65,000 worth of rent in my example, and I want to allocate that rent to the direct service providers, the employees and the contractors, and so, or just the employees. And so what I have is 1, 2, 3, 4, 5, 6, 7, 8 methods of allocation. There's a drop down for each of these. I'm going to go grab the tool in just a second and show you. Salary dollars will allocate based on the percentage of salary dollars for each clinician, or the clinical FTE, or the contractor dollars for each clinician type, or the contractor FTE, or both the salaried and contractor dollars, salary and contractor FTEs, or if you have some costs that are just related to the prescriber, that will just allocate them in that way. Or if you want to override the formulas and directly allocate expenses into the model, you can do that by using the direct method. So that's like, it's really hard to conceptualize that without taking a look-see. So let's go into the actual model. And let me make it big enough so that you have some chance of seeing it. And so here's my template. And you can see that in sections 1 and 2, direct service staff, the allocation method is shaded gray because what we're doing is we're allocating these direct service staff, we're allocating the costs of everything else to these direct service staff. So that becomes irrelevant. And here we come down to our to row 42 where it says direct management staff. So I have 1.5 FTEs, $85,000, and what I have is combo dollars. So what that means is I'm allocating management staff based on the combined salary and contractor costs for the clinician FTEs. So it's $16,576 that's being allocated to the psychiatrist. Now, if I click over to that cell, I see that there's a little arrow that comes up, and I click on that, and I see, let me do combo, change it to combo FTEs. And what happens is, lo and behold, all the numbers change in the columns. So the 16,000 went to 5,400 because when you do it by FTEs, because the psychiatrist makes so much more than everybody else, when you do it based on dollars spent, amount paid to psychiatrists, the allocation is higher. When you do it based on FTEs, the allocation is lower, if that makes any sense. And so, anyways, this is basic cost allocation 101. As you're working on this, if you have any questions after we send this out and you're working on your cost studies, we'll be happy to help with that. So I'm going to change it back to combo dollars. And you can see that every row where there's an other expense. So I have transcriptionists. And in my little example here, I have $50,000 of transcription costs, and I said the transcriptionists are only being allocated to psychiatrists, to prescribers, and so I use combo medical FTEs because none of the other folks are using the transcription expenses. So if I change that to salary dollars, it would spread the costs across everyone. If I change it to combo medical FTEs, it does that. And if it's all just only the psychiatrists, then what I would do is I would change it to direct. I'd overwrite the formula and I'd put in $50,000 into the psychiatrist line, and that's how I would customize the inputs. And so when we get down to the bottom, we have total other expenses, we have total expenses, and then we're going to get into the hourly cost calculations. So let me go back to PowerPoint, say a few more things, and then take a little silence break to see what kind of questions or comments that you have. In section 7, what we're looking for is really quite simple. We're looking for how many paid hours per week each clinician works. We're looking at each clinician type work, sorry. So this organization, in my example, has a 40-hour work week. We're looking at the average vacation, sick, holiday, paid time off weeks per year. In this example, it's 8 weeks. So there's 2,080 hours at work of paid time. There's 320 hours of paid time off. And so people actually at work in this category, these two categories, 1,760 hours. We have 0.3 salaried FTEs that were brought down, 1.0 contractor hours for a total of 1.3, and we have a total of 2,288 work hours. And then we do the math on how much of that is indirect service, is any of that time in travel time, how much is spent on paperwork, meetings and no-shows, miscellaneous other time. So we're asking you to compute or estimate how much time people are spending where in each category so that we have 100% total time. And then we have the direct client time being, what we do the pricing for. So in my example, I'm going to go back over to my example. So $226 per hour for psychiatrist costs, $167 for nurse practitioner. I'm going to go back over to my Excel template, and I'm going to just look at some of the formulas here. So this model is pricing it out based on $310,000 of costs divided by the number of hours, the percentage of time that's direct time. And again, not to go into too much more detail, there's just a couple more things I want to say about this particular study. On the group side, we have this thing called group type 1, group type 2, group type 3, group type 4. So in this example, my groups, I know this is a little funky. Well, let's see, there could be medication groups, actually. So in my group type 1, it brings down my cost per hour. It says, what's the average length of a group? What's the average clients per group? What's the average clinicians per group? So here I have an hour-long medication group that sometimes the psychiatrist does, sometimes the nurse practitioner does. The group has an average of 5 clients, and there's 1 provider per group, and so we get our cost per hour. I'm sorry, our cost per group, which is the same as the cost per hour because that group's an hour long. Group type 2 is a 90-minute, in this example, a medication group, the same number of clients, the same number of clinicians. It's still $45 an hour, but the group itself costs basically $68 for the psychiatrist per client per hour and $50 for the nurse practitioner. So the model has, I said this before, but I'm just repeating myself with visual images. It computes the cost per individual service per hour, and it includes the cost per clinician group, I'm sorry, per client per group and per client per group hour. And there's multiple group types you can have for each clinician type. That's one of the improvements that we made over the 2013 cost study that some of you filled out. As I said a few minutes ago, we also have a residential template and it's really it should be called a per diem costing template. In this case, we've done a handful of projects where this one is addictions residential level 3. So this is an A&D treatment facility. But this can be used for any type of per diem services where we have different residential program categories, and there's a little different model for allocating the cost. But there's still the same help tab that has the instructions, and the yellow boxes are where you put input and can change things. And the white boxes, shaded cells, are all formulas, by the way. And so it's where we're driving to for this particular part of the webinar is what is my cost per unit of service, and really that's pretty straightforward. That's it. We're going to be taking that and running with it in the next chapter, though. But before we go there, what I'm going to do is I'm going to put myself on mute. I'm going to start my timer. I'm going to start my timer and give you about a minute to think about whether you have any questions or comments, and then to type them into the question window or the chat window or to raise your hand. So I'm going to be back in 1 minute. Okay, I'm back. Looks like, let's see, it looks like no questions, and so we'll just go right on. Chapter 3, how to set case rates. Now, this chapter is titled How to Set Case Rates for a very particular reason, and it's way more than setting case rates. It's how to develop utilization management guidelines for each service you wish to price. And there's a very important step that's necessary after you nail down your cost per unit of service. And this is something that's maybe relatively new to you. And this is like really the most critical stuff after you get the unit cost in terms of being able to price your services and contract with managed care plans, the early adopter plans. And so give a man a fish and you feed him for a day, teach a man to fish and you feed him for a lifetime. Create a good tutorial and he can teach himself how to fish. So we're recording this webinar. We're also providing the templates with the help instructions, and we're available to provide technical assistance via email or phone. So understanding the case rate methodology is actually the foundation for pricing capacity-based contracts and capitation contracts, which I'll define or redefine in just a minute. And how to set case rates has an 8-step process. We're going to use an example, but we're going to focus on steps 3 through 8, which is more relevant for you all. This is how a health plan or a provider organization can set case rates all in one. And so the first 2 steps are not really so relevant for you, but it's part of the process that health plans will need to go through to see whether they can afford to pay you the subcapitation rate or the case rate that you might be wanting to negotiate with them. And so I'm going to use an example called the Admirable Mental Health Partners. And this example is they have 30,000 Medicaid enrollees across a 4-county region. The population includes newborns through older adults who are assigned to a number of Medicaid eligibility groups that include Medicaid expansion, non-disabled traditional Medicaid, and disabled traditional Medicaid. And this Admirable Mental Health Partners is responsible for providing a broad set of mental health services to those Medicaid enrollees with a serious mental illness or a serious emotional disturbance. So that's who this particular example is focusing on. And enrollees with mild to moderate disorders are the responsibility of the physical health plan. So this is like you can see it's different than what you're moving into with early adopter. And the Admirable has several years of utilization data for all but the Medicaid expansion population. And so in this case, the key variable is how many Medicaid enrollees that we have, because that's going to come back to help us with the pricing. And so I said 30,000 at the top. I just have it in my little spreadsheet, 30,000. Now, Admirable needs to estimate the penetration rate. And so they're using historical data to estimate how many of the enrollees will experience a serious mental illness or serious emotional disturbance and need community-based specialty mental health care. So we could change this example to include everybody, mild, moderate, serious, and severe, but I kept it at the more serious end of the spectrum to not overcomplicate the example. Since one can never predict the future with great precision, it's important to identify a range of penetration rates. And this metric it's called penetration, the percentage of people that are going to receive care. Now, if we're in primary care, we're expecting 100% penetration, that everybody would get at least one visit a year. But on the behavioral health side, or in this case the mental illness side, we're projecting for serious and severe 9 to 11% as the penetration rate. So if we had 10% penetration rate, what that would mean is that 10% of the 30,000 enrollees would be presenting for care each year. So of course that's 3,000. 9%, 2,700, 11%, 3,300. So basically we're estimating that between 2,700 and 3,300 of these folks would present for care over the course of a given year. Pretty straightforward. Okay, so now we shift gears from with how the health plan is doing projections, and we think about we need to take that population and we need to define the categories of care. And this is a critical part of our pricing model. So for Medicaid enrollees with a serious mental illness or serious emotional disturbance, Admirable has organized their benefit package into a bunch of categories, each with a designated payment method. So this would be an example where, let's see, if I could wave a magic wand for the early adopter region, what I would have is the health plans, the early adopter health MCOs who were awarded contracts in the region would sit down with the provider community, and you would jointly create a design saying we're going to create one payment structure, and we're going to have, and so this would also be the behavioral health organization. We're going to have 13 service categories: call center, outreach, prevention and education, wellness, community-based services, flex funds, mobile crisis, etc. You can see the whole list. And what we're going to do, and one size doesn't fit all for the payment models. And so we're going to be organizing. We're going to pay some stuff on the fire department model, which is called capacity funded. It's generally paid in 1/12 increments based on a budget that supports sufficient staffing and other resources to fill the necessary capacity. We're going to still price some things on a fee-for-service model, which is also known as a payment for volume model. We're going to price some services, in my example, on a case rate bundled payment model that covers the cost of a defined episode of care, and that's what we're going to be playing around with today. The reason why I'm playing around with case rates as my example is because if you can price case rates, you can price anything else, any and everything else. And then the fourth is subcapitation. So, for example, if the providers in an area created an accountable care a behavioral health accountable care organization or a whole health accountable care organization, you would the health plans would pay the ACO per member per month for all the services in the benefit package, and you would be responsible for providing care, the right care at the right time to anyone in the enrolled population who needs that care. So let's go back to, let's think about step 3 of the process, defining the categories of care episode types. So since we're developing case rates for community-based services, in my example, Admirable has drilled down this category to develop 4 levels of care that will be paid different case rates. So I know many folks many of you are working with the locus level of care system. I believe that it's really important for you to consider adopting this type of approach if you're going to your agency as value-based. That we have not only priced out our unit costs, but we've priced out the cost per case. And thanks, we have some questions coming in, and I'll make sure to answer those when I get to a good stopping point. And so even if the payer And you should do this even if the payer wants to continue paying you a fee for service. You should. I think it's really, really important. This is not maybe where you've gone to before. That you need to really think about what is the cost per case type if you want to thrive, just not survive in the new environment. So in my example here, I've created level A, B, C, and D, recovery, maintenance, and health management, low-intensity community-based services, high-intensity community-based services, wraparound act-like level of care. And I've crosswalked these to the locus levels 1, 2, 3, and 4. So we do have some people with serious mental illness that actually are stable, and they actually can do great, thank you very much, at a level A. And so those of you that work with the locus, this will look familiar. So in my example, I'm going to have 4 levels of care, and that's what we're going to play with. We're going to estimate one of the things that you want to be doing, and the payer is going to need to figure out if they're going to consider paying you on case rates, is we need to estimate how many people will be served at each level of care. And fortunately, in my example, they have a long history of utilizing the locus and the CAL locus, so they're able to look at that historical information, which greatly improves the quality of the estimation process. If no such tool has been in place, Admiral would either have to look to other communities for case mix figures and project that over to Admirable's community, or guess, make an educated guess. So case mix, so in my example, we've looked at the data, and 20% of the people are at level A, 37% at level B, 33% level C, 10% at level D. If you're an organization that's developing case rates, you would do this for your clients as opposed to the whole population. And then becomes the most exciting part of the process, which is step 5, estimating the average utilization at each level of care. Now remember that I was saying this is a, quote, technical webinar, not a policy webinar. We're really looking at the steps on how to go about pricing your services. So we've created multiple levels of care. It's important for you as an organization or a plan that's doing any concerned case rates to ensure that organizations serving more higher need cases receive more money, so that the money basically follows the client. And once levels are identified, it's important to determine the low to high range and average hours per case of each level of care. So here I have my 4 levels, A, B, C, and D. I have my average hours in 10, 30, 80, and 110, and I've gone in and I've created ranges. So basically, if I'm creating utilization management guidelines that I'm going to use internally to self-manage the system, I would have a range of minimum to maximum that I would expect to be happening at level A, B, C, and D, and then the average hours. And I'm going to be using these average hours to price out my case rate. Now, there's a tool that will how to estimate hours per level. One tool, I can't remember I don't think we've used this in Southwest Washington. But what it is it's developing sample treatment packages. So here's a template for substance use disorder services. Pre-treatment, outpatient, intensive outpatient plus wrap, etc. And the template is basically for your clinical design, how much for a given episode of care, how much of each type of service are you going to be providing? And we can help you if this is something you find useful. We can tweak this so that there's a substance use disorder treatment package, an outpatient mental health treatment package template, and basically it totals up the hours, it totals up the costs. The cost comes out of your cost study, and it basically says this is the value, this is what it costs for each one of these services. So it's another nice tool to use. Now, the other part of the estimating the cost per unit of service is, so here I have 1, 2, 3, 4, 5, 6, 7, 8, 10 different service codes, and we know that the biggest variable in what the cost per service is who's doing the service. So one of the things that will be important to do your pricing, and so I'm giving everybody like more than just a very small homework assignment, is to say for this service code, what percentage of that work is done by prescribers, by master's level for each code. And then if I know my cost per hour for each clinician type, it actually can give me my weighted average costs per hour, taking into account the clinician mix. And this is part of the model, the cost study model that we have, the template that we're looking at. It goes into a little bit more, it basically spits this stuff out. So, and note that the last column is important for any payment model that you use. If you're getting paid fee for service, you need to know what your clinician mix is so you can know what your average cost per 9001 versus 804, etc. And you can see that that it costs vary dramatically based on the clinician type that's used. Oh, there's a typo here. There's no way that a master's level doing group psychotherapy would cost $275 per hour. So it's also a good way to double check, looking at this column reality test, whether your numbers are right or not. Looks like so there's a few things that are goofy here. That's actually helpful to see that. Generally, the overall cost per hour will be moved forward to the next step, as it says here. So my average rate per hour for everything is $158.62. In the next slide, I've used that $158.62 to price my case rates just to keep it simple. So run the calculations and set the case rates. The following two tables are the results of everything that we just covered in this chapter. The first table shows the case rate figures. The second table computes the total annual budget. So this is a useful piece. So here we have how many, so this is pulling information from those previous slides. What are the average hours? What's the average rate per hour? And here's what my case rates are if I use my average rate per hour. If you were negotiating with a health plan on a case rate, this is basically, and all these numbers were the numbers that you input, this is what you would be negotiating for. Now, in other communities where we've developed case rates, what we've done is there's a whole set of rules around how we pay case rates that I'm not going into today, because this is how to price your services. But for example, level C and level D would almost always be paid on a 1/12 basis, and sometimes level B. So if a person's in care that month, we'll pay you 1/12 of that $12,000 if it's a 12-month benefit period. And then if you take the case mix that we already talked about, and you have 3,000 cases, which is our 10% penetration scenario, and you put on the case rates, you actually, this is like so cool. So if we have a 10% penetration rate and the case mix is what we projected and we're paying these case rates, it's going to cost us $24 million for outpatient services. And we can create a low, medium, and high scenario where we would have lower mix of cases, lower penetration rate, a high scenario where we have higher and higher, and the price, the total budget would change. So when we've worked with HealthShare down in the Portland area to develop case rates in King County and Marion County and places in California. We actually did exactly what we're looking at on the screen as a community, providers and payers, and we said, how much money do we have to spend on outpatient services? Do we have enough to pay these case rates at these penetration rates and these case mixes or not? And it becomes a key part of the model. I'm going to stop for a moment and look at the question that one of the participants put in. Penetration rates, how do we actually come up with a penetration rate when we're combining RSN and primary care behavioral health data? We're now mixing DSHS and Healthcare Authority data. Are there statewide average penetration rates that include the now Apple Health people? Funny you should ask that question. So bear with me a moment while I bring up my Windows Explorer. So the question is, what is the how many people should we be thinking about serving in our two-county region when we're talking about folks with mild, moderate, serious, and severe disorder? And I'm going to add one more thing, which is when we're talking about people with mental health and substance use disorders. So I'm going over to my Frank Chop directory and going to my final reports directory, and let's see. At the risk of bringing up a 100-page file, but it may take me a minute to navigate, I'm going to do that. So bear with me a minute. So let's see. I don't know how much you were tracking, or I don't even know if I've had this conversation with you, but in March of 2015, that was just not that many months ago, we released a report that was funded by a whole bunch of stakeholders for the Washington State Legislature that has a whole bunch of really cool data. And let's see, so let me make this a little bit bigger. And so if we take table 2, it says how many people were in each region at the time of the study. So I'm going to go to Southwest. And when this study was done, Clickitat was still in the pie, but we can help you peel them out. But that's okay. Let's just pretend for a minute that the number that you have is 152,600 folks. That includes Medicaid and uninsured. What the service need is, including mild, moderate, serious, and severe, 37,000 Medicaid, 8,500 uninsured, under 2% of poverty. The number of people receiving services includes people that were served by the RSN system, an estimate of people that were adequately served in primary care. So 15,700, and the gap is 30,000. So let me drill down into the question. So the short answer is I have the data to help you understand how many people need service in the region, how many people are in the Medicaid population, how many people need service. We can update this model for you really quite easily as part of our technical assistance contract. So we can tell you, so this is the mental health report, and again we can tell you what the population is, what the need is So the 37,200 is how many people in the Medicaid population need service, need mental health services, mild, moderate, serious, and severe, not just the specialty care system that was inside DSHS. So this particular report is 73 pages long. I want to just show you a few other things. So the state did a really great study on need rates, and so we actually have need rates by mild and moderate, serious and severe, kids and adults, non-disabled, disabled, and expansion for Southwest Washington. So we have all this great data that there's no reason in the world why, there's every reason in the world why this information should be used in the planning process that is going to be designed after the health plans get identified. And I want to show you that we have the same information. We also have the same, this has substance use disorder need as well as mental health need. You can see here SUD need. So really cool stuff. It's all there, readily available, waiting for you to use, take advantage of, however you want to describe it. As I was saying, in terms of how to price your services, we just sort of kind of talked about, well, we talked about the first set of steps. Do a new cost study, tweak the cost study to reflect the changes you're going to make over the next couple of years, develop the utilization management guidelines for each service you wish to price, determine which payment models you want to contract for, excuse me a sec while I get my computer to convert the results of your cost study into utilization management guidelines and the utilization management guidelines into the relevant payment models, i.e. what payment model am I going to use for each service I provide, thinking about that table that I had. What are my costs, i.e. what do I need to price this out at? And then package your results into a summary document you're willing to share with health plans. So I'm repeating myself from that earlier slide. So let me stop and see if people, I'm going to go into a cone of silence again for another minute to give you a chance to add any questions or chats to me. While I do that, I'm going to go into my computer and pull up one more thing that I want to show you. But please just stop and think about whether you have, I'm going to put myself on mute. I'll be back in a minute. Okay, here's a question or comment. Helpful information for sure, and the scope of this work seems daunting from a time perspective, especially considering all the other early adopter work in normal operations in a medical expansion environment. Do you have a timeline recommendation for phases of this work? Let me use this thing called the Case Rate Budgeting Toolkit case study to answer that question about the timeline. And so here I have a 7-tab Excel workbook. This is another tool, and this tool is the Case Rate Budgeting tool. We hope your stay is a pleasant one. The folks in Portland, or the mental health providers in Portland, were moving to a case rate model with their health plan, with HealthShare, and we took some previous tools that we had and we tweaked them so that they could internally go inside and work on this stuff. And there's a more sophisticated version of how to think about the levels of care for kids and adults, and so there's a bunch of stuff in here. If your eyes are getting crossed by looking at this, it's a little complicated at first, but it's actually very accessible. And here's kind of a one-stop shop where you can project how many clients you have. You can project the clinician types that you have. So I'm answering Bunk's question in a very long way rather than a short way. And you can say, how many cases do I have? How much service ought I be providing? How many clinicians do I have? Do I have enough clinicians to support my clinical design? How much revenue can I generate? How much expense? What are my expenses? And there's another really cool thing in here that, again, I can't remember if I've worked with you before, but it's called the Caseload Analysis tool. This tab can be used to determine caseload sizes based on the number of clients that will be seen in each level of care. And so it helps you think about what are your utilization management guidelines, how many hours per care at each level, what is the average length of stay for a case, and it actually tells you, depending on whether a clinician is seeing lots of low-level clients or lots of high-level clients or something between, how many cases can be on that caseload for kids and adults in order to have enough hours in the week to meet the needs of that caseload size. So here I have kids who have mostly kids clinician who has mostly low-need clients. They can see 52 clients. Here I have a clinician type that sees really high-level clients. They can only see 12 clients. The reason why I went here in relation to Bunk's question is as you move into a world of greater accountability, in order to demonstrate your value, you need to have some internal agreements in your organization around how much service, what are your levels of care, how much service are you going to provide, and basically working on these 6 steps. This is something that's not going to happen overnight, but it's something that you need to basically say as an organization, we need to systematically work on getting to nailing the numbers over the next couple of years. And chances are you're going to have a little bit of breathing room in year 1 of the early adopter contracting. I'll just call year one April of 2016 through December of 2016. And I would suggest that by the end of 2016, or the fourth quarter of 2016, as you get ready for 2017, it's really important for you to have your heads and hands around these numbers. And when I say these numbers, I mean cost per case, service hours per case, what it would cost to, what it costs for each episode of care. And it's real simple. There's a lot of numbers I've thrown at you, but what is my cost by clinician per hour filling out that template? What's the average number of hours per case for each level of care? Multiplying the two out gives you the cost per case. Level of care, average hours, cost per hour, and cost per case. And I don't know if my prediction is right that you need to get this figured out within the next year, but I think that that those of you that, I'm sure that if we fast forward to a year from now, everybody is going to have made varying degrees of progress on this particular journey, and I would suggest that in a year from now, those of you that are further down this path are going to be more prepared at successfully operating in this new environment. I know that one of the things that Adam said at the end of last week is you're getting good at this creates a competitive advantage for you. And not that I'm promoting competition among the providers, but that's just a natural outgrowth of how this whole future is going to play out in terms of healthcare reform. I'm going to just take another minute and see if anyone has any other questions and comments. And then after that, we'll sign off. We will package up the materials that we have. We're recording the webinar, and we'll make that available along with the updated slides, along with the templates that we've looked at today. Okay, so on that note, I'm going to call it a close, a wrap for the webinar. Thank you all for coming. Please feel free to write or call. Here's my email address, and we're going to continue providing whatever assistance you need as you move forward into this approach, April of next year. Thanks, everybody. Take care.